Good morning. The topic for today's seminar is critical evaluation of methods and controversies related to centric relation. It will be covered under the following contents. Coming to the introduction, horizontal jaw relations are those that are established in an anterior, posterior, and mediolateral plane of reference. So horizontal jaw relations can be centric and eccentric relations. Eccentric relations are protrusive and left and right lateral movements. Coming to the introduction, the documentation of central relation from the completely edentulous patients and transforming the same to an articulator is the most important step that helps in diagnosis, treatment planning, and fabrication of prosthesis. Since mandibular movement dominates in this baseline position, it provides a starting point to build occlusion on the denturous and edentulous cast. This baseline position corresponds to the stationary opening and closing axis or the hinge axis. This border position of the mandible is referred to as the centric relation. Coming to the centricity of centric relation, it was first proposed by GYSI'S and then accepted by many authors. However, the word centric is perhaps objectionable as the condyles do not lie exactly in the center of the glenoid fossa as proposed by many authors. The centric jaw relation is the central position of the hub of the mandibular movements. Coming to centric occlusion and centric relation, centric occlusion is a tooth-to-tooth position while centric relation is a bone-to-bone relationship. Both these may or may not be identical to one another. In dentulous, centric relation is not and need not be coincidental with centric occlusion, while in edentulous case, centric occlusion and centric relation are made to coincide. So, centric relation has two dimensions and hence it is called dual centric. The first is the condylar centric relation, which is the condyle disc fossa eminentia relationship, while the mandibular centric is the maxillomandibular relationship. Both these should coexist and termination of mastication, deglutition, swallowing all return the mandible to this baseline position. So the terminal baseline position of the mandible is more important than the condylar position. So more than 40 definitions are currently available for centric relations coming from GPT-1 to GPT-9. The controversy pertaining to the centric relation is the position of the head of the condyle in the glenoid fossa during the CR position. This ranges from a retruded posterior position to a superior position to a anterior superior position. So finally, Dawson in 1973 defined central relation as the most superior position of the condyle, which it can assume in the glenoid fossa when it is not unstrained. So coming to the changing definition of central relation, first McCollum in 1920 demonstrated that condyles execute a purely rotational hinge movement when the operator guided the mandible to the position the condyles is in the most retruded position in the glenoid fossa. And McCollum named this position as centric relation, and he was the first to record the hinge axis of the mandible. Secondly, coming to Granger in 1952, he suggested a second component should be added, which is a superior position, and this was necessary for bracing, as the condyles would be unstable when it was only in the most posterior position. Then the rearmost, uppermost, and midmost condylar position came into being, which is the rump position. In this, a medial component was then added for a stable condylar position, and it was considered a physiological condylar position harmonious with the centric occlusion. However, in 1977, the American Equilibration Society challenged this position as it was considered to give pressure on the retrodiscal tissue at the bilaminar zone and proposed the most anterior, most uppermost position of the condyle against the slope of the articular eminence. So coming to GPT-9 definition, which is the most recent definition, which stated the centric relation is a maxillomandibular relationship independent of tooth contact in which the condyles articulate in the anterior superior position against the posterior slopes of the articular eminences. In this position, the mandible is restricted to a purely rotary movement, and from this unstrained physiological maxillomandibular relationship, the patient can make vertical, lateral, or protrusive movement. It is a clinically useful, repeatable reference position. Now coming to coordinated muscle function at maximum intercuspation. So at maximum intercuspation, there is release of the inferior lateral pterygoid muscles during the elevator muscle contraction, which is the goal of occlusal harmony. So this coordinated muscle function is only possible if the condyle disc assembly can completely seat up into the respective fossa during closure into maximum intercuspal position. However, if there is a disharmony between occlusion and TMJ, the condyles are displaced from the centric relation to the maximum intercuspal position. So the inferior lateral pterygoid muscles contract to move the mandible to the maximum intercuspal position. So the condyles must be pulled forward and hence and they must be pulled forward since they are pulled in the forward direction. Coming to incoordinate muscle functions, if the TMJs must displace to achieve maximum intercuspal position, the inferior lateral pterygoids actively contract to hold the condyles down on a slippery incline. So this is in direct opposition to the contraction of all the elevator muscles every time the teeth are brought into maximum contact. So EMG studies have shown that muscle hyperactivity and incoordination is a result of occlusal disharmony. As stated by Dawson, mandible is in centric relations if the below 5 criteria are fulfilled. First, the disc is properly aligned on both the condyles. Secondly, the condyle disc assembly are at the highest point on the posterior slope of the articular eminence. Third, the medial pole of the condyle disc assembly is braced by bone. Fourthly, inferior lateral pterygoid muscles has released its contraction and is passive. And fifth, the TMJ can accept firm compressive loading. So what is adapted centric posture? It is the manageably stable relationship of the mandible to the maxilla that is achieved when the deformed TMJs have adapted to a degree that can comfortably accept firm loading when completely seated to the most posterior position against the eminences. So the 5 criteria for adapted centric posture are: the condyle comfortably seated at the highest point against the eminentia. The medial pole of each condyle is braced by bone. The inferior lateral pterygoid muscles are passive. The condyle to fossa relationship is manageably stable, and the load testing procedures produces no sign of tension or tenderness in either of the TMG. So coming to the concepts of point centric and long centric, point centric is seen when the centric occlusion and centric relation coincide. So it is a precise location of centric occlusion and centric relation. It is a maximum intercuspation seen or given in centric relation. It is a type of organic occlusion. A long centric of freedom in centric, however, is seen when centric occlusion and centric relation do not coincide. So a freedom is given for the mandible to either close in centric relation or slightly anterior to it with a smooth gliding without affecting the vertical dimension. So freedom in centric is about 0.5 mm at the occlusal and most often less than 0.3 mm. So how do we know if a patient needs a long centric? So when the patient is asked to sit upright, relaxed, and in a straight position, and with gently tapping of the teeth together, it should not result in striking of the upper lingual incline before complete closure to the closed position. So when the patient is asked to close in centric relation, the patient should not glide the mandible slightly anterior and hit the upper lingual incline. The patient should either close into centric relation or slightly protruded during the posterior closure without striking the lingual incline. So before doing this, all interferences should be eliminated, and if centric relation interference is present, then the path of closure will be dictated by the proprioceptors instead of the muscles. So the most important aspect in this is that the vertical dimension of occlusion should not be altered. So what are the methods of recording long centric? So to determine if a patient has a long centric, two different colors of marking ribbons are used. One is the red and the black. The black ribbon is used for marking the centric relation points, while the red ribbon is used for marking the slight closure from the postural rest position without the headrest. So when the red mark is ahead of the black mark, each centric stop should be extended forward at the same vertical level, and whereas the centric relation mark should not be ground. So for this, a knife edge inverted cone carborundum stone is used for accurate grounding. Now, when the red mark is in coincident with the centric relation mark, there is no long centric. However, if the red mark extends forward, there is need of long centric. If the red mark extends backwards, then there is an improper centric that has been recorded. And when the black centric marks are completely missing, equilibration is incomplete. So what is the significance and features of centric relation? Now this position is the most definite in the vertical relation and it is independent of presence or absence of teeth. It is recordable, reproducible and repeatable over a period of time. It acts as a reference relation for establishing an occlusion. So when centric relation and centric occlusion of artificial teeth do not coincide, there is instability of dentures and the patient will be subjected to pain and discomfort. Also, errors in mounting the cast on the articulator can be detected when central relation is used as a horizontal reference position. Coming to the rationale for recording centric relation is used to establish, it acts as a guideline or a starting point to develop occlusion with artificial teeth in harmony with various structures, including the TMJ. Most of the occlusal surface intercuspate with each other centric position. And when maximum intercuspation coincides with centric position, there is stability to the processes, preserving the health of remaining tissues. So what are the factors which influence the centric relation records? First is the resiliency of the supporting tissues, whether the tissues have labi, the stability of the recording basis, which is very important while recording centric relation, the TMJ and its associated neuromuscular mechanism, the nature of the pressure applied, whether it is minimal pressure or heavy pressure, the technique in making the record, and the associated recording devices, the skill of the dentist, the health and cooperation of the patient, the posture of the patient, the maxillomandibular relationship, and the size and position of the tongue. So what are the concepts in recording centric relation? There are two different concepts. First is a minimal closing pressure technique. So in this technique, the tissue supporting the bases will not be displaced while the record is being made. So objective of this is to make the opposing teeth to just touch uniformly and simultaneously at the first contact. So the advantage is being there is uniform contact which will not stimulate the patient to clench the teeth and it will relax the closing muscles. The second is the heavy closing pressure technique. In this, the tissues under the recording basis will be displaced when the record is being taken. So the objective is to produce the same displacement of soft tissue as it would exist when heavy closing pressures are applied on the dentures. So the disadvantages are that it can cause uneven contact, which tends to clench, when the patient tends to clench the teeth. There can be soreness on the denture base and change in residual ridge. So out of these two, the use of technique based on minimal closing pressure produces the best results. Now, what are the difficulties encountered in recording centric relation? First is the biologic. It arises from the lack of coordination or synchronization of opposing muscles when the patient is asked to close in the retruded position. Secondly, it can also be caused by habitual eccentric jaw position adapted by patients to accommodate the existing maloccluding dentures. And thirdly, it can be caused due to any neuromuscular diseases. Secondly, coming to psychologic, this involves both the prosthodontist as well as the patient. The prosthodontist must be prepared to calmly spend adequate time in recording centric relation records. Thirdly is mechanical. It can be due to purely fitting bases and hence we should ensure that before recording the centric relation, the bases fit perfectly. If they can interfere with each other during the excursion movements. So coming to recording the centric relation, it can be by manipulation of the mandible and by interocclusal bite records. So first coming to Dawson's bimanual palpation method. So the Dawson's bimanual palpation method is the most consistently repeatable and the most easily learned. It provides a method for verification of correctness of the condylar position, the alignment of the condyle disc assembly, and the integrity of the articular surfaces. So coming to the Dawson's bilateral manipulation. In the first step, we recline the patient all the way back and point the chin up. This prevents the mandible from protrusion. In the second step, we work from a seated, working from a seated position from behind the patient, and the head is firmly stabilized so that the patient cannot is not able to move the head during the manipulation of the mandible. Thirdly, when the head is firmly stabilized, the four fingers are positioned on the lower border of the mandible with the little finger below the angle of the mandible. In the fourth step, the thumbs are brought forward to form a C with each hand. So this is done at the this is done just above the symphysis of the mandible. In the fifth step, with gentle touch, the jaw is manipulated so that it slowly hinges open and close. No pressure is applied and no jiggling. Just romancing the mandible so that the condyles are seated into the place where they are supposed to. When this is done, upward finger pressure is applied and downward thumb pressure. In the last step, when it is possible to freely and painlessly arc the mandible while exerting firm pressure, the dentist is ready to close the mandible to the first point of contact. The mandible should not translate off its terminal hinge axis. So the methods for assisting the patient to retrude the mandible are: we instruct the patient to relax the jaw, pull it back and close slowly and easily on your back teeth. Secondly, get the feeling of pushing your upper jaw out and close your back teeth together. Thirdly, protrude and retrude the mandible repeatedly as the patient holds the fingers lightly against the chin. The patient is asked to swallow and conclude the act with the blocks in contact, tapping the occlusal rim on the back teeth together rapidly and repeatedly. Tilting the patient's head backward at the neck, palpating the temporalis and masseter muscles to relax them, and the boost series of stretch relax exercises. So there was an study conducted by Hobo, which conducted a study to find the reproducibility of mandibular centricity in 3 dimensions. So 3 different methods were used, and it showed that the bilateral manipulations were the most consistent reproducibility and is recommended for centric relation registration. So in the second part, we will cover the methods of recording centric relation. In this, the first method being first classification being by Boucher, which is divided into static and functional method. Hartwell were divided into functional, graphic, and tactile or interocclusal check record methods. And last is the Mayo classification. So coming to the static method, so in this the dentist checks the bite technique. The direct check bite technique was the first technique to record central relation and was introduced by Foff, the dentist of Frederick, in 1756. It is also called the squashed bite technique. So the advantage of this is that there is minimum displacement of the recording basis, and the record is made of wax or plaster with or without intraoral or extraoral tracing devices. So this is the tactile or interocclusal check records. It is also called a non-precision jaw relation recording by placing a thermoplastic or rigid material between the rims and guiding the patient to close onto the material. So the factors which influence the interocclusal records are uniform consistency of the recording material, stability and compatibility of the record basis, comfort of the patient, minimum amount and equalization of pressure. It is indicated in situation of abnormally related jaws, supporting tissues that are excessively displaceable like flabby ridges, large tongue, uncontrolled mandibular movements, and also to check the occlusion of teeth in existing dentures. So in this, what we do is that the index is carved, which prevents the occlusal rim for recording material. This index rim is placed in the mouth and bite registration wax is placed in the trough and is softened. And the patient is asked to close in the centric relation. Once this is done, the registration wax is chilled and carved and the completed record is made. The record is then again verified by placing in the mouth. So what are the criticism of interocclusal method of recording centric relations? So first, Schuler in 1932 stated that he did not consider a record secured on compound or wax occluding rim sufficiently free from error to complete the restoration without additional check. Now, on 1923, considered and modified the interocclusal wax method. He pointed out that the resilience of tissue-bearing denture supporting areas might contribute to the distortion of the record. So he advocated the positional relationship of the maxilla to mandible under no pressure technique, which will minimize the error. So Hanna put forward the zero pressure philosophy, while others put forward the minimal pressure technique. So then Chula said that modeling compound is preferred, and it should, as it softens more evenly and does not release stress, leading to distortion as much as wax. Then Simpson felt that wax records were unscientific and commented that such methods as holding the jaw back and closing the mandible are unscientific. Payne and Hickey stated that the dental plaster was most preferred material because of rigidity and its setting time. Wright in 1939 suggested that no pressure technique should be used to record the centric relation. Brown in 1954 suggested that centric relation can be obtained by having the patient bite repeatedly on the softened occlusal rims, but it was concluded that centric occlusion obtained from this technique was due to habitual motion of the joint and not the true technique. Green then suggested a new technique by breaking the memory of muscles and recording the centric. He held the jaws apart and once the muscles were fatigued, he guided the patient to bite on the rims to record the centric relation. Then he made orientation lines and troughs and to reorient the following removal from the mouth. Later, GYSI'S tested this method and never got the same recording twice with wax or compound, and he suggested that there would be an uneven cooling of the material produced, which in turn produced distortion. So he said that the only accurate material was plaster. So Berman in 1960 conducted a study to find out which was the most accurate interocclusal record, and he said that zinc oxide regional impression paste offers no resistance to closure. So there was a comparative study to evaluate the compression resistance of different interocclusal materials. So imprint bite, virtual refill, jet bite, and Ramitech was used. After all load testing with different thicknesses used, it was found that the compression resistance found to decrease with the increase in thickness of for all the interocclusal recording material, and virtual refill polyvinyl siloxane bite registration material exhibited the greatest resistance to compression. Coming to the functional method of recording centric, it was based on the principle of condylar movements in centric and eccentric relation, that is the protrusor, retrusor, right lateral and left lateral. So Green utilized a combination of pumice and plaster and placed it between the maxillary and mandibular occlusal rims and guided the mandible to do centric and eccentric movements. So in the first method, as a needle house method, needle introduced 3 metallic studs. These 3 studs were mounted on the maxillary occlusal rim made of compound, and the patient was asked to perform all the mandibular movements. Based on these movements, the studs grooved on arrow tracing on the mandibular occlusal rims. So the articulator was then programmed with the obtained functional groups. Then House modified this needles technique and introduced 4 styli to make the needle point tracing. Later, Patterson introduced modeling wax to make a record of centric relation. So in this, troughs were made in the maxilla and mandibular rims, and dental plaster plus carborundum mixture was placed in the trough, and patient was guided to move into centric and eccentric movements to obtain the desired curvature. So both these methods require tentative interocclusal wax record of centric relation, and both these methods adjust the recording median at the height of the vertical jaw separation. The correct vertical is established as the patient closes the mandible. So coming to the criticism of functional recording method. So the functional method of recording centric relation requires very stable record basis in this method. The displaceable basal seat tissues, resistance of recording mediums, and lack of control of equalized pressure in the eccentric relation contribute to inaccuracy. So patient needs to have a good neuromuscular coordination to participate in the functional method of recording centric. Coming to the graphical method of recording centric. So the Gothic arch method is the most commonly used technique which records the relative movement of the mandible, the jaw in centric and eccentric movements. So graphic methods can be used either as intraoral or extraoral. In 1866, Balkic stated that Gothic arch tracing depends on various movements made by the mandibular arch. The first known as needle point tracing was by Hesse in 1897, and the technique was then improved and popularized by GYSI'S in 1910. So, in what are the factors of importance while making a graphic tracing? So, the central bearing point should be located in the center to avoid pressure or displacement of tissues or recourse due to unusual movement of the central bearing point when the mandible moves from centric to eccentric. So if the central bearing point is off center, there may be displacement of the record basis during exertion. And if the central bearing plate is not used, the occlusal rim will offer resistance to the horizontal movements. So when the tracing should have a sharp apex, which is known as the position of the centric relation. If it is a blunted apex, it will be an acquired functional relationship. So these are intraoral traces that are available. So coming to the intraoral tracing, firstly, it has a pointed screw-in bearing and a tracing device mounted on the mandibular rim and a plate that is mounted on the maxillary rim. So the intraoral tracer combines a central bearing point and a tracing device. The plate is covered with a marking substance and the central bearing pin is connected at the proper VD, and when the rims are in place, the patient is instructed to perform the lateral and protrusive movements. So as these movements are performed, the Gothic arch form is traced on the plate. So this was the Gothic arch form, and the hole may be drilled at the apex of the tracing to ensure that the patient jaw is in the most retruded position when the registration is being recorded. So the advantage is that the bearing and the tracing device is strong enough to resist the biting pressure and can be held in position. The disadvantage is mainly since it is intraoral, there is difficulty in visualizing the tracing. The intraoral tracings are very small, hence it is difficult to find the true apex, and the tracer must be seated in a hole at the point of the apex to ensure accuracy while injecting plaster between the occlusal rims. If the point moves the rims before they are secure, the record shift on the basal sheet will destroy the accuracy. These are the types of extraoral tracers. So coming to the extraoral tracing, a marking or a recording stylus and a tracing or a recording table is attached to the upper or lower arches, and a central bearing device is screwed to provide a central bearing point or support between the maxillary and mandibular occlusal rims. So this is the tracing device. Then this is the recording plate. The technique being, we need to make stable maxillar and mandibular record bases and contour the wax occlusal rim and establish the vertical jaw relation. A faceboard transfer is done and maxillary cast is mounted. At the tentative centric relation, the mandibular cast is also mounted, and the condylar elements are secured against the centric stops. So the mandibular occlusal rim is then reduced, and the central bearing device is mounted. The patient is asked to sit upright, and the recording bases are placed with the recording devices. There should be no interference between the occlusal rim when the mandible is moved in any position. Retract the stylus and conduct the training exercises. When the patient is proficient in executing these movements, the tracing plate is prepared to record the tracing. When acceptable tracing is developed by dropping the stylus to the record plate. When a definite error point tracing with a sharp apex is made, the patient is asked to retrude the mandible to the centric relation, and quick setting dental plaster is placed. So once that is done, the assembly is removed and the mandibular cast is mounted with the new record. So coming to the classification of arrow point tracing, the Gerber describes 6 different types of Gothic arch tracing. The first is the typical type, which has a well-defined apex with the symmetrical right and left lateral components. The mean Gothic arch angle is 120 degrees. So this reflects a healthy TMJ without any interference in the condylar path and a balanced muscular guidance. The flat form is similar to the typical form, except that it has a more obtuse right and left lateral tracing. So the Gothic arch angle is more than 120 degrees. So this signifies a marked lateral movement of the condyle in the fossa. Third, coming to the asymmetrical form, in this the left and right tracing meet in an arrow point. However, the inclination of the protrusive path is not symmetrical. So this may be seen as which indicates an inhibition of the forward movement either in the right and left joint. Coming to the apex, which is absent of the round form, in this there is no sharp apex. However, the tracing is more rounded, so it usually shows a weak retrusive movement. So the tracing should be repeated until a definite arrow point is obtained. Coming to a miniature arrow point, it is similar to the classic, but the tracing is small due to limited mandibular movements. So it can be due to restricted neuromuscular coordination, improper seating of record bases, being edentulous for a long time, hence there is inhibition of the mandibular movements. Coming to the double arrow point method or double arrow point, it is a record of habitual and retuded centric relation. It allows patient training and it should be repeated till a single Gothic arch is obtained. It can also be seen when the vertical dimension is altered during registration. Coming to the dorsally extended arrow point, here the protrusive part of the mandible movement extends beyond the apex of Gothic arch. So guidance provided by the mandible may be strained and retrusive movement of the lower jaw either by the patient or the operator. It also sometimes is an artifact caused by the forward displacement of the record bases and the backward dislodgement of the mandibular occlusal rim while removing forces from the mouth. The registration should be repeated to confirm the same. Coming to the interrupted Gothic arch, there is break or loss of continuity of the lateral incisal path of the Gothic arch. This happens due to posterior interference at the heels of the occlusal rim during lateral movements. The atypical form, in this form, the protrusive component does not meet at the apex, but it is at one of the lateral paths. This may happen in dentulous cases because of faulty muscular pattern, which can be due to parafunctional habits like bruxism. It is also seen in very old edentulous patients who are using complete dentures with an incorrect centric relation. So coming to the comparison between intraoral and extraoral Gothic arch tracing, intraoral tracing, since it is intraoral, it cannot be observed, hence it loses some value of visible method, while extraoral can be observed. In intraoral, the tracing is made closer to the center of rotation, since it is small. The extraoral, the tracing is made away from the center of rotation, hence apex is more discernible. Here, intraoral tracing is small and hence it is difficult to find the true apex, while extraoral is easier to find the true apex. In intraoral, stylus cannot be observed during injection of injecting plaster during centric and eccentric records, while here in extraoral can be observed and the patient can be guided more intelligently. In intraoral, lips remain in passive contact and the subject can perform mandibular movements more comfortably, while in extraoral, lips do not contact each other. So coming to the critical analysis of graphic recording methods, here in the arrow point tracing, it is difficult to record the centric in excessively resorbed and flabby ridges, large tongue, prognathic or retrognathic patients, as it can cause instability of the braces. So Grango in 1952 insisted that needle point tracing is not a reliable method of determining centric relations, since it is recorded in a horizontal plane only. And he said that the central relation should be considered a vertical rotational relation related to the hinge axis. Since the intraoral tracing is small, it is difficult to find the true apex and too much patient cooperation is needed. Also, the tracer must be definitely seated in a hole at the point of the apex to assure accuracy when injecting of the plaster between the rims. So, Solomon also claimed that in intraoral method, the errors are likely to be less because the tracing is located closer to the center of rotation of the EMJ. As compared to the extraoral tracer. However, the presence of an extraoral tracer attachment prevents the lips from meeting each other, and according to him, the distinct advantage of intraoral tracing is the ability of the subject to perform mandibular movements with lips in passive contact. So graphic method is not indicated when there is inadequate intra-arch space because it is difficult to accommodate the tracers. A sharp arrow point tracing cannot be obtained in patients with TMJ arthropathy. In these instances, we need to use a conventional wax closure method. So, Kapoor et al. In 1957 conducted a study to evaluate the centric relation caused by various techniques. So, he suggested that the intraoral tracing procedure and the extraoral tracing procedure were more consistent as compared to the wax registration. In patients with flabby ridges, these tracing devices are less consistent as compared to wax registration. So, the difference in consistency between intraoral tracing procedure and extraoral tracing procedure is not statistically significant. Nandini et al. Conducted a comparative evaluation between the different tracers, and she said that there was no significant difference between any of the tracers. So, there was a systematic review to compare different methods for obtaining centric relation. So in these various methods, studies which evaluated various methods were used as the guided methods, graphic method, physiological methods, and 7 articles were included in this review. So the review concluded is that based on the guided methods and swallowing technique, it is not possible to conclude which technique has the greatest reproducibility of centric relation. However, it is possible to suggest that in most cases, intraoral Gothic tracing is more superior or equivalent when compared to the guided method. Coming to the newer, that is the digital Gothic tracing, here the stylus is placed in a plastic sphere of 6 mm in diameter and is attached to the maxillary ring with an autopolymerizing resin. And a resin film sensor is attached to the conventional tracing device that is attached to the mandibular occlusal ring. Coming to pantographic tracing, in this, it is a graphic record of mandibular movements in all 3 planes registered by a styli on the recording tables of a pantograph. So it is a 3-dimensional dynamic registration procedure, and there are 6 styli and tables that are attached to the maxilla and mandible by clutches. There are 2 tracing tables that are located adjacent to the condylar area, and 2 additional tables that are located in the anterior horizontal plane. So the pantographs record the most posterior position of the mandible to the maxilla, the right and left border movements, and the protrusive path of the mandible. So it can be mechanical and electric. Now, the electric pantographs are the most accurate to record centric relation. However, the equipments are very sophisticated and are not generally used in the fabrication of complete dentures. Coming to the axiographic technique, in this, it is an electromechanical devices are used to produce mandibular motion in centric and eccentric movements with the help of transducer, record controller, and a duplicator. So, the shape and range of the movement of the axiographic tracings are useful. However, it cannot be used in severely resolved ridges and abnormal neuromuscular coordination. In this technique, the record can be transferred to a fully adjustable articulator. Last, coming to cephalometrics, which is described by Piot and Schaeffer, the proper centric relation and the vertical dimension of occlusion were determined by cephalometric radiographs. However, it is impractical and never gained much usage. So to conclude, the accurate determination, recording, and transfer of jaw relation records from the edentulous patient to the articulator is essential for the restoration of function, facial appearance, and the maintenance of patient health. The skill of the dentist and the cooperation of the patient are probably the most important factors in securing an accurate centric relation record. These are my references. Thank you.